and welcome to another episode of Purvis Versus. My name is Eric Purvis. I'm a massage therapist, course creator, continuing education provider, curriculum advisor, and advocate for evidence-based massage therapy. In this episode, we welcome Anna Maria Mazzieri. She's a soft tissue therapist, a continuing education provider, and she also runs her own school in the United Kingdom called the Soft Tissue School. Over the last few years, Anna Maria has become a good friend and professional colleague of mine. In this episode, Anna Maria and I discuss a variety of topics, with our main theme focusing on evidence-based practice and what this means in clinic and the education for massage and manual therapists. We address the topic of defining expertise in manual therapy, the importance of qualitative research, and how important it is for all manual therapists to stop searching for singular causes of pain using outdated models. If you enjoyed this episode, please rate it and share it on your favorite social media platforms. You can also support my podcast by making a donation, so please visit buymeacoffee.com/helloob. And Purvis Versus can be found on YouTube, so please check us out there and subscribe. Thanks for being here, and I hope you enjoy this episode. Well, hello everybody. Today I get to welcome the most wonderful Anna Maria, my favorite Italian Brit that exists. From Devon, is that correct? Is that where you are?
Correct. Thank you. Favorite Italian Brit. I like that.
Yeah. I was like, how am I going to introduce that? I was like, yeah, that's fantastic. So thanks for being here, Anna Maria. We've had many great conversations before, and I think one of the podcasts that I was on of yours about 2 or 3 years ago, with I think it was
that long ago? Was that long? It's time to do another one.
Yeah, that one for me that I did with you was, I've had more emails, messages on social media, comments from anybody that listened to that one than any other podcast I've ever done. So I don't know if I've ever told you that, but that one changed my life. I think it really got my name and kind of things that are important to me, which I think are important. Got that out there to the world, so thank you.
No, wonderful.
Yeah. So let's just introduce yourself. Tell us a little bit about who's Anna Maria, and tell us what you're all about.
Oh, it's always very difficult, isn't it, talking about oneself? Well, I always say I identify myself as a soft tissue therapist, and a soft tissue therapist is in the UK is a title that we have adopted from the origin that used to be clinical and sports remedial massage. We have adopted this title because we wanted to come out a little bit from clients to identify us only through our modalities. So to us, soft tissue therapy was encompassing a tiny more of a broader skill set, which is about treating the person with different, like with communication, with the reassurance, with massage, with rehab advice, and so on. So that's why I identify myself as a soft tissue therapist. I have been in practice for 22 years, although I came to this country, to England, to study archaeology. So still working with the bodies, but these ones are alive. So then I moved on to massage therapy just as I remember I did a course just for interest a summer, and literally fallen in love with it. All of a sudden things like made sense, and I progressed into more clinical aspects of massage therapy, and I'm just fallen in love with it, and I've been in practice ever since. I attended a degree in sports therapy because I want to go to do my master's in neuroscience and psychology. So hopefully, as long as we don't have another COVID tragedy or anything like that, hopefully 2024 is going to be the master's year for me. And but I'm also very active in educating. I started teaching because I always been very disappointed. I found that what I was taught at college never made sense of what I was seeing in clinical practice. And So I kept doing courses and courses to try to find making sense. And I never made sense. In fact, even now, it's quite difficult to make sense. And so I started educating as well. I started teaching. And really, again, I found a new way, another passion of mine to actually share in the room with. I love when people come into the profession that they do not have an experience in the profession, and they come in with the most amazing original questions that one doesn't even think about sometimes, and still, even after 15-year teachings, I got the students coming in that says, oh, but what about this? And I thought, oh, I never thought of that. So I love these challenges from the students. So now let's say that I share my time between clinical practice, which for me is really important, because that's where I truly learn the experience of our clients, but also teaching. I teach quite a bit for both courses, qualification courses, diploma courses, but also CPD, which in your country, I think you call this CEU. And also I've been very, very lucky. I feel very privileged that recently I have been part of 3 studies with an international group of outstanding researchers and clinicians. One study has been published. It's about manual therapy in different pain phenotypes, and the other 2, they are in going through review at the moment. So I felt really privileged because I do not have any experience in research apart from being an avid reader of research. But I think it was wonderful that in this case, Chad Cook appreciated the value of expertise away from research, and it was great. Yeah, because when we had to put down our what do you call it, credentials and paper publications, some of them had 100 plus publication. Mine was a fat zero. Zero. But that was interesting because, again, then the question comes, how do we define expertise? Does expertise, for this case in manual therapy, is expertise in manual therapy one criteria to consider oneself an expert? Is that of having published work? It's years of practice. How does one? So that was interesting. So just a little bit of a shout out about the paper.
Yeah. No, we should send me the link to that. I know I've read the paper because I believe I was one of the people that submitted some data for that.
Correct. So we sent, yes. And what I really liked, there were already some, let's say, limitations. Even the fact that it's divided into pain phenotypes, I have some reservations with it. But we decided, it was decided to take the IISP, the association, the National Association of Study of Pain definitions, and then work from there. So that's fine. But what was really interesting is the type of study. So we are trying to find more qualitative studies and becoming better at qualitative studies, and that I think has to be praised, credited for sure.
Yeah, I liked that the paper, and I've read it when it came out, but it was a couple months ago now, so I can't really remember what came out, what the findings were. But my bias is towards qualitative stuff. Some of the work that I did in my graduate studies was qualitative, and it just, to me, I mean, okay, you need both, right? You need quantitative, you need numerical data, but you also need the stories and the experiences to kind of get a better picture. Personally, though, I feel like in soft tissue massage, manual therapy, qualitative to me seems to make more sense, because it's more about what somebody's experience, who maybe they have this type of pain phenotype, and then so say you could study like, well, what's your experience when you get manual therapy? What's that mean to you, and how valuable is that to you? And you can ask kind of, I feel, more clinically relevant questions in a qualitative study than you can.
Yes, but also because according to what you want to, what question you want to have answered. So obviously, if we want to find cause, RCT is the best.
Of course, yes.
However, and obviously, of course, in our profession, RCTs are still valuable. However, we know that there is so much, there is limitations, because it's very complex in our profession to mitigate some of the contextual factors and so on. So that's why I think qualitative we can look at different things with qualitative, and this is the point. And please tell me if I'm going a little bit off track, because I think this is quite important. Do we need to change the way we research, or do we need to change the questions we're asking? Because you see, do we really need to know now why the cause, in this case, the exact mechanisms? I don't think that, yes, we need to know, but shouldn't we focus a little bit more on, actually, let's move away from the mechanism and see what is the person's experience within the context that create a positive outcome. 100%. Instead of looking what is the causation of that particular effect. Why providing a deep type of stroke or high velocity thrust will affect pain? No, let's have a look instead how, and this is one of the other side, what are the gaps in research? And this is the other study that is going to come out soon, hopefully as soon as it's been reviewed. But this is another, should we start changing the question we're asking?
I think it's a great idea. Sorry, I didn't mean to interrupt there. No, I think it's yeah. Because so often, right, we see this, and I know you and I spend probably more time than you want to admit, kind of trolling through some of those massage therapy and soft tissue therapy discussion boards and whatnot, and there often is this search for this causative factor for everything, right? And that tends, to me anyway, I see that as leading us kind of down this path that it's never going to end. And because we can't fix it, right? So I like what you said, like, what's their experience? And that's what we should be, where our focus is on predominantly for what we do clinically. So asking
absolutely. I was on this conversation very recently in one of the forum with a lovely, I think he's a McTimony chiropractor, lovely man, Phil Greenfield. And what he did say, we're talking, he said, but Anna, how can you communicate? She said, if we're not looking for cause, how do we communicate that then to the client? I said, actually feel what I'm trying, in the last few years, I'm trying to do with my clients is moving them away to wanting a cause for the problem. What I'm trying to explain to them that experience of pain or injury is come because different risk factors, which have been building up at a certain time, all of a sudden, boom, they got together at the right time, in the right amount to drive that particular experience. So it's not a cause, because I think that's where our responsibility, we need to help our clients to get away from wanting that singular cause, to validate, being able to validate, because they want the singular cause. This is what makes sense in myself, because having the singular cause validates the pain or their experience. But we need to make them realize or help them to make sense of the experience without being validated by one cause, especially not being needing to be validated by one physiological cause. This is why it's really important to me that we talk about risk factors.
Yes. And this is something we see all the time clinically, and I saw this for years and years, always in clinical practices. People would come in and they would be like, "Oh, I hurt because of," and insert the narrative here, this causal thing, and then they would, and then you say, "Okay, well, have you had been treated for that, and how does it make you feel?" And you kind of get to try to tease some of the stuff out of there. "Oh yeah, I go to see my chiro, I see my physio, I see my other massage therapist or whatever, I get injections," and but they still had pain, even though their cause. And so then I found that it allowed us to have a conversation. Well, maybe that's not the cause. Like maybe that's just that there's other things going on that may be part of it. So you never want to dismiss it because you want to validate them, right? But and most people have never had those type of conversations, or never have had a clinician try to explore something outside of this singular cause. Because what we see a lot in the chronic pain population, so you were talking expertise earlier, our clinical expertise and my clinical experience suggests that what most people that are given a singular cause for their pain and they're treated ongoing, they're still in pain, so it can't be that singular cause. Unless it's some type of inflammatory condition or disease process.
Correct. Yes. So obviously there are some very strong nociceptive drivers, which that's where coming back to the AISP differentiation. I don't mind it. There are some limitations because sometimes the main driver of the pain is nociception, but the experience of it that affects their life, the suffering that comes out of it, it's still multifactorial. And this is where, especially as massage therapists, but I do think everybody in healthcare, but especially as massage therapists, our role is to help them to make sense of the complexity of it, and supporting them through that. Yes, I often also say, some of my, let's say, let's call it speciality is to help you through the biomechanical risk factors. I'll help you to build the load, reduce the load, improving range of motion. So that is a little bit more my specialty. Still psychologically kind of driven practice. But that's where, I probably work more is with the exercise, with the massage. So a little bit more those biomechanical factors. But at the same time, I bring them awareness that actually you probably are feeling the pain more today because you just said to me that you couldn't sleep last night because you had all this, thinking about having to go back to work after having the child, and also the fact that your child doesn't sleep very well at night and is not feeding very well. So, these are part of the pictures that irritates your system. That's how I often. So going back to the causality, I love the work that Cause Health did years ago. It's about, let's try to go away from one single cause in healthcare. We're too complex for it.
Yeah. And this is where the theme of what we want to talk about today was kind of evidence-based practice. I think this kind of fits into that, is that, is the evidence-based kind of ideals, which is where we should be going as a profession. What I seem to feel and understand from reading the arguments that others make is that there's a lot of people that say, "Oh, evidence-based practice is good, of course," but some people are like, "Yeah, but it's too recipe based, it's too prescription based." And I was like, well, that's actually is not what it is, but there's that misunderstanding. And so just to kind of further on this conversation here is that, like, you have your clinical expertise, there is these causative factors, there's these risk factors. If you are having an evidence-based practice, you are looking at all of these things, not just a singular thing. And I think that's something that is misunderstood amongst many people in
Massively,
the profession.
massively. And it really kind of saddened me because they use that explanation of recipe cut, I love what you just said, as a justification for saying, oh, in a person-centered care, we don't want recipes. Therefore, how can you support evidence-based practice? My argument with that is that, with all due respect for those people that says that, I think they have a deep misunderstanding of what evidence-based practice is. You partly mentioned it there about the three key elements of the judicious application of clinically relevant current evidence, good quality evidence, with therapist expertise to cater for the client needs. But actually, I think we need to go a little bit further. We need to go further in thinking, how can we use what we know in evidence to cater for this person? So often people ask the wrong question. That's why one of the main things that I teach when I teach the evidence-based modules is the PICO question. How you need to learn the right question to ask to the evidence. What I find often is that people are seeking support for what they already do. While instead, the way I would love us to be thinking it is, I have somebody coming to me with Achilles tendinopathy. Okay, let's have a look. What does evidence tells me about, one, the Achilles tendinopathy, two, the lived experience of the person, three, the communication regarding the therapeutic encounter, four, in our case, is touch. Put all of that together. How can, through my expertise, because again, some people think putting together what they learned over the years. No, how do I translate all the beautiful evidence and actually put it together a little bit with my clinical experience? How do I translate it so that it actually fulfills the client's needs? And this is why we are just too narrow when we seek an answer to a question for evidence. We still think that it is about going and reading a paper about the efficacy of one intervention. It's more than that. It is way more than that. It's things like, for example, and this is why, when they say manual therapy or touch, is short-lived, yes. But short-lived, we know also that there is body of evidence that's saying to us that for responders, that a short-lived pain relief, short-lived symptom modification is diagnostic of better outcomes. So even that, if I know that somebody, I know the evidence is telling me that, if I know that maybe with that person that knows in the past might have responded to touch, I might want to use touch. Yeah. So it is complex. It is up to us educators to make it less complex to our therapists, but it's more complex than the cookie cut.
No. Yeah.
And ultimately, sorry.
No, go ahead. No, so go ahead. I'll intervene after.
Ultimately, this is the best we have at the moment. And although we need to try, so to me, the limitations of evidence-based practice, they're not strong enough to vouch for people not using it.
Yes.
So we cannot find those drawbacks or the limitations and say, oh, because of that, I'm not using it. I don't think it's a good enough excuse.
What I was going to say too, is you're talking about the people who get short-term pain relief after manual therapy too. It's also important too for us to understand in using taking that person-centered approach, which is part of evidence-based practice, right? There's always these catchphrases, right, that everyone throws together, and
word salad.
Yeah, where there's I mean, that's maybe a different conversation. We could talk about all that stuff. But is that meaningful to the person? And that's the thing that needs to be understood or asked as well. Is it's like, okay, so I'm going to give you this treatment. These are some techniques or an approach that has worked in the past when I've seen this, and if they get some relief. But is that meaningful to them? Is that helpful to them? Do they care? And that's something that is missed, I think, too often, is that we're like, oh, this person didn't respond to what I did, so therefore they can't be helped. And I've heard that a lot from clinicians. And it's like, well, maybe it's just what you tried didn't help on that day, but maybe tries a different, and maybe you should try and find something else that works for that person.
Or maybe, what you said there has really made me think of something. That's great, Eric. Or maybe for that day, the primary outcome wasn't the pain relief.
Yeah.
This is the point. We should always ask, what is your primary outcome? Because sometimes I might not be able to reduce the pain with my touch, but I might be able to hold the space of safety, which on that day is more meaningful for them than being pain-free. That, I think, is a really, really powerful thing you said there, actually. Yeah.
And how many times too, I'm sure yourself and others that are listening to this podcast, has somebody come in and you're like, oh, tell me what's going on. And they tell you this big story about their shoulder, their neck, or their back. And then you're all of a sudden your clinical reasoning hat goes on. You're trying to figure it out and ask some questions. And then you're like, I know I've done this before. And you kind of stop yourself and be like, is this something you want me to something to address today? No, can I just get like a nice massage for, just to chill out for a little bit? And you're like, oh, you just want like something, you don't even want me to address that concern because that's not what they're looking for, their objective for that day. So that's something too I think we need to ask, because that happens to me. That used to happen to me all the time.
That made me really think, Eric, about going back about the misunderstanding of people about evidence-based practice. I've recorded a podcast quite recently, and for a group that, let's say, it's not known for following evidence-based practice, because all they're very modality based. Okay, very modality based. And so I was trying to, me and my colleague Amy, we wanted to do a podcast with them, because we wanted to make them understand that didn't matter at what level of practice they were, didn't matter what modalities they practiced, having been evidence-based, or at least been evidence-informed, it would have been very refreshing and liberating, and indeed open up so many more options for them, and understand the limitation of the experience they provide, and maybe using a different language could have provided much more let's say, how can you say, much more create better outcome for the client, even if there are experiences that they're nothing to do with healthcare. Anyway, so the host said to me, so we're talking about evidence-based practice, and they said, oh, but what about if all those therapists don't want all these big words and they just want to give a massage? And all of a sudden, and I really like the host, is the kindest and the most caring therapist, but that really triggered me because to me, all of a sudden, in my head came, well, it's not your choice. There is a point where if you want to work with people that they are in pain and they have an injury, so in the moment in which you open your doors to public, to members of the public who actually come to you because they say, I have a shoulder pain and I would like you to help me with this shoulder pain, the decision of what and how to approach, or if you are evidence-based practice or not, is taken away from you. Rightly so, because actually, the moment that you're working with people in pain, you are becoming health care. Yes, it might be non-registered healthcare practitioner. It might be complementary healthcare, but still healthcare. In the moment in which is healthcare, we have an absolute duty of care, again, towards those people. Or do not harm. Harm, now we know, it doesn't come with what we do with our hands, but it will come with what we do with our words. So if I say to somebody, you know, your reflexology, doing a reflexology session, which might feel absolutely beautiful, I've got nothing, you know, it's a beautiful experience, it's brilliant. But if you start in saying, oh, you know, you got sciatica, let me do a reflexology session because, you know, the reflexology session will help with your sciatica, that's a little bit creating nocebo. The other thing is, and this is, to me, is even more important, by having somebody on your couch that should be on somebody else's office where they can be treated more efficiently and effectively, therefore the experience of suffering or pain reduces. In the moment in which we keep them in our couch and we don't give them the choice to go to somewhere else, that to me is malpractice. I said it last night at the red flag course I run. I said, don't you think that every single client that comes to us, they think, well, I trust the therapist. I trust that the therapist knows. I trust that the therapist keep up to date. And I trust that the therapist has my absolute best interest at hand. And if they think that there is something out there that it is tested and tried to be more effective or quicker effective, then surely the therapist will refer it to me. I think every single person that comes through our doors, they think that.
And they should.
So they should, yeah. So the fact that the therapist says, oh, you know, let's try this, let's try, no. What do you know about the particular condition? Is there anything we know that can work better? Is there anything that we know that could? Because it doesn't mean that you don't need to be part of this. And, you know, Eric, tell me if I'm going a little bit off, you know, off cut here, but it is okay in the moment in which we want to, as I said, in the moment in which we want to work with people in pain, we take on a responsibility and we have to. However, it is also okay to say to somebody, look, you come to me because you have sciatica and you found reflexology really helpful before. Look, I am very, very happy to provide a reflexology session because this is the experience that you want. And it's beautiful, it's the time for yourself. However, for the sciatica itself, I refer you to my colleague, the physiotherapist down the road, or the chiropractor, or the osteopath, or back to your GP. They're going to take care of that. However, I'm going to give you an experience which is so powerful for their stress, even their you know, in experience of reflexology, somebody likes that, will downregulate the fears, will downregulate the nervous system. So there is value to that, but a value that is not healthcare. This is, for me, is really important. It's leisure and it's good. And I even said in the podcast, if doing ceremonies with crystals is what ticks you, go and do the ceremony with crystals. But do not use them for people in order to, as a therapeutic intervention. You know, use it as somebody wants to expand their consciousness. Somebody wants to have an experience, a different experience. This is enough to wanting, a beautiful experience, but it's very different from healthcare. This is where there should be a not a fine line anymore, a strong line. If somebody's going,
yeah,
so
I know. I love that.
Sorry.
Yeah, no, sorry. I love that, Anna Maria. I think because this is something that I think you and I have had conversations about this before, but it's a conversation that's not had very often about the ethical dilemma of the kind of pseudoscientific approaches that are so common in our world. And so often when we call that stuff out, and you talk about crystals, you talk about reflexology, or you talk about any other type of narrative or understanding that is common in the profession, when you challenge that, people get very defensive. Because the ethical thing too about the like do no harm and informed consent is something that we should talk more about, and it's so important for people to understand that. And this is something else that probably, I mean, we could talk forever about this, would be things like the informed consent. So you talked about the fine line between healthcare, right? So you're selling something or a fix or some therapeutic value that doesn't have evidence to support it, even though maybe you have clinical experience that says, oh, I do this thing and people feel better, right? But you don't have a plausible biologically plausible explanation, or you don't have evidence to support that. Then if you want to be a healthcare provider, you cannot make those claims of therapeutic benefit. You can say, hey, this is something that might help, but we don't know why, we don't know how. Do you want to give it a try and see if it helps with your experience? That's a fine line. I could get behind that, as long as you're not selling it as some optimum therapeutic benefit. And this is kind of goes with what you're saying too about these modality industries, those modality empires, where they are definitely wanting to sell their approach as being, this is the best approach, this is the only way, and they're making a killing selling that. But ethically, right, the people, if you're selling that and that's what you're telling your clients, you're not getting informed consent. Or you have a duty they have a duty to understand what you're doing, why you're doing it, and
that's my point with what the client believes of us. I bet they believe that we are totally up to date with knowledge. Call it evidence, call it knowledge, but we are not. No. That's where I think actually there is no informed consent there then.
Yeah, and that's a big problem. That's something I'm surprised that doesn't get talked about enough. And that is something that I have been on about for quite a few years, and most people have just look at me with the glazed eyes and have no idea what I'm talking about. So I'm really happy that you have similar thoughts and feelings.
It's massive, because I bet if it goes to court, God forbid, but if it goes to court, I bet that they will not have a chance, because it's actually I would have been expecting that what you were offering me would be what is or at least that what you're offering me, it's equal to something else that is effective. Because I do not mind somebody, like you just said, the clinical expertise, blah, 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 blah. First we try first we work evidence-based. Sometimes, because of context, we know that very well, especially with touch, things might not respond very well. That's why I use massage and touch and manual therapy, because manual therapy just provides me that kind of change of context. And then the same, approach, the same exercise might work better because of the change of context. In those situations, I'm quite happy to say, look, in my experience, this is so important, because then the client makes the choice. It's, I can say in my experience, so they can weigh the knowledge in the right way, knowing that it's only one person experience. If they're happy with that, we can try that. As long as that experience doesn't take away the person's choice to go somewhere else where they will end the suffering earlier. And this is where, for me, is the biggest, absolute the biggest. As I say, and you know what I absolutely loved talking about? I absolutely love going to the psychedelic conference in Exeter quite recently in June. And it was amazing because they give so much respect to the naturalistic approach of psychedelics. So the psychedelics conference was a very academic conference for psychedelics in mental health, but also in pain. There is research coming up, but we need to wait. So it was a really, really good. But what they did, they showed tremendous respect for the more naturalistic approach to psychedelics. No, I'm not talking just, taking magic mushrooms to go and having a good time. Talking about more about plant medicine. And I really enjoyed how these very high-level academics, they looked at the naturalistic way, like the shamans and so on, and now say, what can we learn from those way of using psychedelics? And I think we can do the same. So how can we learn from the use of certain modalities, what the certain modalities provide and might help in healthcare? There's a very different thing to say, I use those modalities for healthcare.
Right.
Because the line of, I want to get better, and therefore I'm going to go to somebody that I'm hoping they know best about that particular problem, it's a very different say, oh, I just want to go somewhere because I want a good experience. And that's a big line that to be made.
Yeah.
We don't, it's us needed to make the client aware that is a line, and that they can come to us for having a really great experience if they want, or to therapists, to have a great experience, and that's very beneficial as part of something, but not as healthcare.
And this comes down to something I've been on about for years. It is a failing of the kind of entry to practice education. And I know things aren't regulated in the UK like the same they are here. All these problems we're talking about, the lack of evidence in practice, these ethical dilemmas, kind of fix-it, causative approaches, all these things we've talked about today. These are not things that I would say people are making up on their own. These are an industry problem because this is the kind of narrative that people are taught in their entry to practice program. And so people are spending a lot of money and time to learn, and they're basically will be taught a bunch of different modalities and some anatomy and physiology and kinesiology and some pathology. So there's stuff in there that you need to know, but there's also, what do we do with this information? It almost always comes down to, what modality do I choose to help to fix this problem or to correct this dysfunction? The problem for me starts like from day one when you're in your massage or soft tissue training. And then it just gets built on from there. You have an entire industry, so like these modality empire industries that are built on this framework that is, we know now, is incorrect.
What modality do I choose? This is, you just hit the nail in the head. This is where, when before I said about changing our perspective of evidence-based practice, this is why we need to change our mindset. We shouldn't think what modality should I use. We should think, how can I support and facilitate that person to achieve the primary, whatever the primary goal is? It could be pain relief, it could be improve range, it could be going back with playing rugby, whatever. With one, evidence tells me, two, my skill set. So how can I support that? So with some, and this is where we need to be looking at the clients like we look at in education. What are the needs? How does that particular person learn or understand? Because I also say, and it's, when people come through our doors, when they see massage, they are self-selecting. So the people that already have taken the choice to come to you because they already know touch, they already know that they won't touch. So for us, it's a little bit easy. We know they already are expecting touch and therefore we know that most of the time they will respond. They are responders. So we have to think what is the person, how is the person going to better make sense of the pain, and how to then recover from the pain, from the injury. And this is our skill set. It's not the modalities. Our skill set is recognizing the person, what they need, how they need it. Some clients need to actually have less of a massage and more of the discussion when they come in. Some of my clients, they enjoy more the movement aspect of it, so I have the conversation during the movement. And some of them, I have the conversation, the encounter, the interaction during the massage itself. It's about the client in front of us.
Yeah. And that's something that I find that when I teach my courses, when I do my live courses, we often talk about, communication and touch and movement, exploration and all these things. And people often are like, well, when, like, how much do you talk to the person? Like, do you do like a long intake or whatever? And I'm like, well, it really depends on the person, right? Like, we can do a lot of these things while we are, while they're on the table or while we have them doing some movement stuff. But there is this thing in our profession that we feel that we're not providing value unless it's all hands on. If someone pays for a 60-minute appointment, like, some people are like, well, I have to give 60 minutes hands on. And I'm thinking, well, maybe if the person comes and they just want a great massage, then yeah, give them as much as they've paid for. But maybe the person comes in and they come in because they want pain relief, or they want to improve their function in their ability to I don't know, do some specific activity. They want to be able to, like, look over their shoulder or raise their arm above their head so they can grab things from the top shelf. And maybe that's going to require not just an hour of hands-on stuff. So we should ask those questions and say, well, what would a successful treatment today look like for you? And they're like, oh, well, I would like to be able to, reach above my head. Okay, does that require 60 minutes of hands-on? Like, because if the person told you that's what they want to do, and they leave the appointment being able to do that thing a little bit better, then they don't care how many minutes of hands-on they had. And this is very anecdotal. This is my experience. But when people tell you what they want and you help them achieve it, they don't care how they get there.
I couldn't agree more. It's about exposing the client to what their outcome could look like. Yeah. And the other thing is, from a clinical perspective, we need to stop saying 60-minute treatment. They're booking 60 minutes appointment. In that appointment, we decide together with our client what that looks like. And this is, again, is where our skill set is. If I know that there is a client that they're expecting that, I might create let's call it an environment where on the first appointment, I might deliver some of the information while they're having the massage. And then slowly, I'm taking them out of it. Because actually, if they come in for pain and, particular injury, I want them to get away from thinking, I just need to come in for a massage to get my pain or the range of motion of, going back to function. I want people to see, I'm very, I bang on about it, but massage or manual therapy is only the context. Mm-hmm. It's a great context. I love it. I love providing it. My client love receiving it, but it's only the context in which the really true interaction takes place, which is therapeutic alliance, communication, which provides reassurance and advice on lifestyle and, helping them to make sense, and all these other really meaningful and valuable aspect of the therapeutic encounter. Manual therapy is just literally is the environment where it takes place, the context. Some people do understand, do feel more prone to understanding when they get touched. There are reasons for it, and which is absolutely fine. And this is why we are in practice, because some people do respond to that. Not everybody, but some people do. And that's why, and if we like doing it, we like providing manual therapy, then, you're matching people's needs.
Yeah. Yeah. That's such a great point. And I love these conversations. So thanks for saying that. What are your thoughts on like, what are your thoughts on these modality industries? Like, do you think it's ever possible that our kind of shared professions here are ever going to be able to move past these kind of modality approaches?
Are they wrong? This is my point, though. Are they? Is the modality that is wrong, or is how what we use the modality for? So, for example, we still teach in our school modalities in terms of, let's call it MET techniques, or a little bit of cupping, but we teach them as part of a varied type of touch, and I differentiate them. So massage is something, massage gives that long sustained touch. And other techniques like, let's say, cupping, it's a different type of input sensation. So that's how I see them. And I don't dislike that, because sometimes it's nice to have the variability of touch for the person at that time. What I'm having a little bit of an issue, and I am afraid that in this country we don't seem to get away from it, is that they see those modalities as the intervention themselves and the intervention itself. And they put so much focus on it, and they cherry pick those studies, not very high quality either, in order to give an explanation of that. And we don't need that. You can use cupping, as long as it's not the kind of cupping that gives you all that, what do you call it? I don't know what you call it, dry cupping that gives you all that.
Blister.
Bruises. No, we use a very simple, sometimes little silicone cup, just to provide a different sensation, because the client at the time might like a different sensation. That's why I use kinesio tape. But my client knows that I use kinesio tape just to give you a different sensation, not because it does anything particular, special. And this is where I think we're having a little bit of a problem in our industry. We're still considering the modalities the driver of the outcome. I don't think that it is. I think we need to switch. They're only one part of the communication process, and they're not what creates the outcomes. And
Yes.
until we change that mindset, until we really think, we really understand that it's more than that physiological effect, I don't think we can. It's not even about being evidence-based practitioner here. It's about understanding that the person's pain and injury and experience is very complex. It's way beyond the effect that acupuncture might have.
Yeah. And this is such a, I'm glad you kind of clarified that a bit, because I often will go off about like all the different techniques, and I'm not against the modalities. Like, I'm not against, like, because there's different strokes for different folks, right? There's different approaches that you can take. There's some people like the like a pokey. Some people like the kind of like nice flowing sweet. Some people are going to want the more kind of stretch skin stuff, which people would call myofascial, like there's some people want the light touch or the MET. Like, there's different approaches, which I have no problem with, because I think it's great to try different things, because a different intervention might have a different impact on person, right? So not everyone's going to respond the same, and we all know that clinically. Like, sometimes you feel like you've done nothing to somebody because you've just kind of like held their head for 45 minutes, and but that's like the most powerful massage experience.
That's what they needed. That's right?
Yeah, but the issue I get is when the modalities are sold as doing something magical.
Correct.
And that's when my talk about modality empires is that they're like, this is the best approach. But what I am noticing though now, and I'm sure you noticed this too, is that a lot of these modality empires are now starting to throw in terms like biopsychosocial, evidence-based, person-centered, pain science. And they start to use these catchphrases, which I mean, we use them too, you and I know, because like it tries to explain what it is we're doing. But now I'm starting to see that, particularly in the last probably 3 or 4 years, that everybody else is using these too. And I think it's confusing for the
It's
customer.
dangerous. Yeah,
Yeah.
it is. Very recently, I noticed somebody that, let's say that until now, they sold their own method. Okay, you use this method for chronic pain and people will get better. So that in itself, using a method for chronic pain and you get better, that is the opposite to what evidence-based practice is. Because one of the things that we know from a strong body of evidence that there is nothing superior to anything else for persistent pain. So just somebody that, anyway, but recently, because they realized a lot of people in the UK, a lot of therapists are more and more, I think that they're starting understanding and seeking a bit more evidence-based, or at least being aware of evidence-based training. So they are asking that, and I think recently they advertised for something, and I kid you not, it was a word salad, talking about, what was it that they said? They put within one sentence the biopsychosocial, person-centered, and something else. And I thought, yeah, but you just put it in literally to attract, probably for SEO purposes.
Yeah.
Because you're selling a method. They're selling an absolute method to advertise, they're advertising their own method, which is herbs for, chronic pain, but they put in there the words by BPS and the words person-centered, and I think, oh my God, this is why people don't understand. Because then what people do, and this is what I realized on the podcast I was recently, they're trying to shoehorn modalities into an evidence base. And this is not, of course, you can shoehorn anything, but it is the absolute mindset that is different.
And that's one thing I always like to, one of the things I focus on so much when I'm doing my live courses is, bring whatever technique or modality you want to the workshop, and you can use whatever technique or modality you want in your treatment room. But what we're going to focus on is we're going to focus on how do we apply the clinical reasoning of whatever it is your favorite technique is to the population or to the person that's in front of you. So if we're doing a low back and pelvic course, for example, like, people often, well, what techniques do I use? I'm like, well, whichever ones you want to use, right? Maybe these ones might work better for depending on the presentation, and we try and have conversations and discussions on that and demos to trying some different things. But I see that if we focus on just like identifying by a modality, we are missing the bigger picture of the person, and we are attributing every single thing in their experience to some type of dysfunction, which that modality can then fix, in air quotes.
At the same time, though, Eric, I am a strong supporter of, let's say, honing in or refining touch. So I do think that it's actually good to attend some techniques courses, because it helps you refining your touch.
Yes.
Because actually, and again, this is total clinical experience, there are some type of touch that are more comfortable than others, like broad, long, slow strokes. And somebody that has been in practice for many years and touched and provided touch with different bodies, they would have experienced that. So learning from those people to create an experience. This is the difference. We are creating an experience. With manual therapy or massage in our case, we are creating an experience. In that experience, there is an option for behavior change to take place. And this is up to the client. We are just there to facilitate an experience. What they do with that we can help them and support them through that. But it's not the experience that creates the change. The experience provides the option. And how can I make that experience absolutely magnificent? Is provide that beautiful touch sometimes that gets the person lost in their own body.
Yes.
And this is why I love, the link between touch and interoception. There is some evidence coming out of it. Or the Laura Case, who is amazing. She's doing some fantastic, really good research on touch, on deep touch. She's actually trying to eliminate as many contextual factors as possible. And what she had discovered that not only tactile fibers gets processed into the insular cortex, where then they're processed with emotion. That's why tactile fibers, light touch feels pleasant, but also deep touch. So what she has found that the deep touch stimulates the same pleasurable pathways than light touch. And would that make anything different for what we already do? No, but it's really good to know. It's really good to know why the deep touch. And then you wonder why, again, this is total personal clinical experience. The people that you do those long strokes, nice and deep strokes, they say, they feel quite, let's say, they feel powerful. It's a powerful experience. Of course, if they're nice and long and slow, you have more time to internalize. There is more time to connect the discriminatory touch together with the affective touch. So there are a lot of things happening. So the myofascial people, when myofascia, says, oh, wow, I feel so upright. He said, you feel upright because you changed the fascia, or you feel upright because actually you had time to process sensations.
Yes. And that's a less wrong explanation that you just provided, less
wrong. Bravo, less wrong. It's not what exactly is happening, but this is what research is there to provide a less wrong explanation.
And when we have that less wrong explanation, that allows us to be more ethical and allows us to be more evidence-based in our approach. And I do like what you did say, though, too. You did say that there was the, you do encourage people to learn different modalities. And I think so, too, because it's a matter of comfort, right? If you only know how to do Swedish massage and somebody doesn't respond to that, then you don't have another approach. So I personally, for me, I've taken lots of different modality things in my career. It's been a while since I've taken one because I feel like they're all kind of variations of the same thing. If you are someone that just right out of school and you're totally aware of all the evidence-based knowledge that's out there, and you're like, yeah, okay, I know all this. I know all the pain science. I know person-centered stuff. And I've had conversations with new grads that are like, come out like fully like, yeah, I've listened to your stuff. I've listened to so-and-so stuff. Like, I know all this stuff, but I just need more tools. And I'm like, yeah, then take those modality courses, learn some different approaches. That's great. Just don't believe the BS that is often, not always, often being sold. Because there's value in that.
We run hot stone courses.
Yeah.
I love hot stone courses. But we're not gonna, when we run our hot stone massage courses, we do not build a narrative about the benefit of the heat or it's a narrative about experience. That is enough. You just don't need anything more than check the contraindications and make sure that it is suitable for the person. Apart from that, it's all about the experience it provides to the client. Because it can be such a pleasant, wonderful, warm, experience that actually that down-regulates the nervous system. And then we can go when I talk to them about, for example, let's talk about, challenging that overhead movement, there is more chance that we'll do that because the pleasant approach establish or reinforce our therapeutic alliance, but also created a safe space in the brain to now do something that originally could have been a little bit more challenging.
Yeah, the best massage I ever had in my entire life was a hot stone massage by somebody that was not a trained therapist, but just somebody who just was good at doing it. And the treatment I got, like, that was the most delicious thing I've ever experienced. It was so good. And it really opened up my mind to realizing that, like, the power of a positive clinical presence with a touch that feels good goes a long ways. Now, what's going to be missed, obviously, is pathology or understanding of mechanism stuff. But if you're just looking for something great, I mean, I still think, that was a couple of years ago, that was the best thing I ever experienced. I've never been able to find another massage that even came close to that.
I'll give you an example. So let's say, somebody, she's suffering with frozen shoulder and it's at acute stage. It's really, obviously really suffering, and she wants to keep away. She'd gone through the GP and she wants to keep away from pain medications. So she comes to help with maintaining the range of motion she has, to help her with a little bit of pain, but also to give herself, like she says, I want a bit of a respite from suffering. So we work with that. I do a little bit of hot stones, because on the shoulder, it makes her feel really good. Then we can manage to do a bit of mobilization. When we do a bit of mobilization, all of a sudden it says, oh, that's it. I got a little bit more movement than I thought I had. Not because I increased the range of motion, it's because she feels so pleasant. You used the beautiful word delicious. Then actually contractile mechanism and a little bit switched off probably. So we could see what her potential was. So she accessed that potential. Then she goes home and they say, look, in the next few hours, show your brain that you still got that potential. So for that particular hour that she was in the clinic, her experience took her away from suffering. Does she knows that is the massage doesn't cure her frozen shoulder? Of course she does. But does that mean that she should not be using it? No, she has been given all the other options. We looked at all the other options between me and the GP, and she actually says, I'm okay. I will go through it. I know that it's pain. I know that it can get better. I just want to be supported through this time. This is what we're there for.
And that makes it powerful too, right? Like that, it's when we talk about the
liberating.
Be dismissive of kind of some of the stories and the different things that people learn. It doesn't mean that what we're doing doesn't work. It doesn't mean that what we're doing isn't helpful. And that's the thing that we need to understand, that when we are challenging kind of the status quo of narratives and of beliefs in the profession, it doesn't mean that what we're doing has no value. Because that's oftentimes what people hear. Like, oh, you tell me I'm useless. I never once used that word. That's what you think when you hear that what you're doing isn't working the way you think you're doing. But you've got 20 years of clinical experience, which is showing you that people are getting better. So don't think that what we're saying is telling you that you're useless or that you're not a good therapist. It's just that there's newer, more updated knowledge which needs to be adopted, and we can incorporate that into what we already do, providing these beautiful massages.
Yes.
And even probably be more powerful when we understand kind of the bigger picture of how our manual interventions can potentially impact a person.
And this is if we say, my final message would be, it's not just changing a narrative, because it's more than changing a narrative. By your narrative, although the client might come out of your room feeling really good, the narrative you give of the treatment, it can provide a nocivic effect on a long term. So the client might come to you and you say, oh yes, it's because your pelvis is rightly rotated or left, whatever, the sacrum or whatever, all this rotation, and you treat and they feel better, say yes, because I put the pelvis back. There and then they will feel great, yes, because it's a neuromuscular response. Of course they feel great after massage, after touch. But next time they got the pain again, what they're going to be thinking? They're going to be thinking, oh, I'm in pain because my pelvis has gone out again. And therefore I need to go and see Anna Maria again. And that is dangerous. We know that the person thinking of fragility in the body, and I thinking of the pelvis going out of pain, there is fragility, does not have a good outcome for them. Well, instead, if you say, well, actually, you're feeling in pain because there are all those risk factors. Some of it is biomechanical, i.e., not pelvis out of play, but strength deficiencies or inflammatory drivers. Some of them are more systemic. Actually, biomechanically, you could have had those risk factors for 20 years. However, you're feeling them more now because maybe you're starting perimenopausal. So it's actually not the biomechanical risk factors that the driver is the perimenopause. So should we go and discuss with the doctor possibility of HRT? So this is what our role is to provide those options. Yes, then if it's the driver, we can decrease some biomechanical drivers, but not by readjusting pelvis. So ultimately, the narrative, it's the first thing that somebody must change straight away.
Yes. And that's a great final thought, Anna Maria, because yes, understanding narratives are important, but they aren't the only thing, because we can't justify everything by just changing the narrative. But we'll just leave that thought there, that the narrative is important. And, hopefully anyone that listens to this understands that we, as educators and advocates for our profession, strongly believe in the power and the wonderfulness of what our profession can do. But we are just pushing for us to realize our potential on opposite sides of the pond to do better.
I am still in practice after 22 years. I used to be strongly biomechanic. I used to run all the anatomy trains courses. So I used to be very strongly biomechanically based. If somebody like me embrace when evidence-based practice came into my vocabulary, and I got my views why it didn't beforehand, and I'm not ashamed of it, it's just our industry has changed. It actually was liberating, because all of a sudden you start realizing all the quirky things you see in the clinical practice, that certain things don't make sense. When you are looking at the evidence, all of a sudden you think, that makes sense. And it's so liberating, because you realize it's about you and the client. And there is no cookie cutter. It's about the relationship is the most absolutely important. So yes, it's liberating.
Yeah, I would agree. That was my experience too. Is I took all the anatomy trains courses, and I was heavily invested in that as well. And then, yeah, once you start to learn some of the current evidence, it definitely allows you to poke holes in those things, and it starts to make sense now why you had some successes and why you had some failures.
But let's say, sorry, Eric, to stop, because that is something that I feel very, very, because I thought about it very deeply. Why we all embraced the anatomy trains of the fascia movement is because it happened at the time where we all been in practice for a while, and we started realizing, you know what, the biomechanical approach is not the beginning of the end. So something was started with, then we go into those fascial anatomy trains courses. And this was at the time where fascia research started like having a bit of a resurgence. And what the fascia research showed is that everything is interconnected, which we were seeing in practice. They took it more biomechanically, but already they gave us a bit of a vocabulary, and this made us think, oh, in fact, they used to talk about fascia containing emotions and so on. So it actually gave us a bit of a explanation, a vocabulary for what we were already seeing. We didn't have any other vocabulary to use because evidence-based practice didn't come into our industry as yet. But then once evidence-based practice came in, we started realizing, oh, actually, that is a way, I'm much less wrong with that. But that's why we all jumped on board of fascia, because it was the first time it was the absolute first thing that moved us away from the very strict biomechanical perspective and more of a comprehensive, integrated movement in the body. So it made sense to all of us, because we were starting to think, oh yes, I sure see that. But then when the true, the biopsychosocial model, which is the closer model to the way we see health and pain, we see health at the moment, or the neuromatrix of pain, we are again less wrong. So I do understand where people went down onto the fascia route. I totally get it.
Yeah,
I was one of them.
Yeah, and me too. I'm the first to admit, that I was that, and it made more sense to me at the time. And then it's just a constant evolution, I think, of thinking and of our clinical, trying to make sense of our clinical experiences. And maybe 5-10 years from now, what we're talking about will be, maybe we're completely wrong now.
And that's okay.
That's okay. I think we have to be mindful. But I think we know we are less wrong now than we were with the anatomy trained stuff. And that's okay. That's the best thing that we can do. That's all we can ask.
Absolutely.
So anyway, Henry, that was lovely as always. Thank you so much for taking the time to be here. And I look forward to having some conversations with you in the future. And hopefully we can make it work. I can come meet you in person next year in the UK.
Wonderful. Yeah, we look forward. We're trying to get you over now for the last couple of years. On the third year, we will manage to get you over here.
Can't wait.
So it will be fantastic. Thank you very much for inviting me, Eric.
I appreciate all you listeners for taking the time to be here. If you enjoyed this episode, please give it a 5-star rating and share it on your favorite social media platform. You can follow me on Instagram or Facebook, where you can find me at Eric Purvis, RMT. And please head over to my website, ericpurvis.com, to see a full listing of all my live courses, webinars, and self-directed course options. You can connect with Anna Maria via her website, thestschool.co.uk. Until next time, thanks for listening.